Today we will discuss about the adrenocortical carcinoma. So what is adrenocortical carcinoma? It is a rare malignancy with an incidence which is on very lower side, that is around 0.7 to 2 per million. Its incidence in southern Brazil is high, probably because of specific germline mutations, high prevalence of T53 pathogenic variant, and its incidence is slightly higher side in case of women, more so in fourth and fifth decade. The other risk factors are also there which are responsible for this. Several hereditary tumor syndromes are also associated with an increased risk for ACC. Among them, the life from many syndromes should be kept in mind. Others, as we have already discussed, that up to 80% of children with a diagnosis of ACC harbor a T53 pathogenic germline variant, and 4% of adults with ACC carry a germline T53 pathogenic variant. As discussed in last slide, there is a predilection for the female sex, which does actually it doesn't make any difference in our clinical decision making in terms of prevention, diagnosis, or therapy. As of now, no established environmental risk factors have been identified. Other syndromes like Lynch syndrome, that is hereditary non-polyposis colon cancer, also found to be predisposing condition in around 4% of cases for adult ACC. Screening for Lynch syndrome can be conducted by staining for the 4 Lynch syndrome associated gene products by immunohistochemistry of the tumor and microsatellite instability testing. Others like MEN1 have a higher risk for adrenal tumors. Also, ACC may also occur because of that. Others like some molecular evidence of an involvement of WNT beta catenin signaling pathway in ACC pathogenesis in case of familial adenomatosis polyposis. Also can be part of Beckman-Wiedemann syndrome and also in Carney's complex. A familial cancer syndrome can be observed in up to 10% of patients with ACC, and therefore a detailed family history can further streamline the genetic testing, which should be considered in any ACC patient for T53, that is life from any syndrome, and depending on other information from tumor analysis or family history or other genes to look for, that is MSH2, MSH6, MLH1, PMS2, as well as MEN1, APC, and PRKR1A. Identifying a predisposing germline variant will further inform treatment, that is whether immunotherapy for like Lynch syndrome, and also will help us to give caution in view of like using radiation therapy for the life from any syndrome. Also, to look for other family members, the testing and future define also help in future surveillance for the cured patients and at-risk family members. Tumor testing for the somatic variants provides insights into the potential therapeutic targets. It may present in form of adrenal incidentaloma in around 10% of cases, and so most adults with the ACC, that is around 50 to 60%, present with signs and symptoms of adrenal steroid axis, and this possibility of functional tumors is more so in case of children. Rapidly progressing Cushing syndrome with or without virilization is the most frequent presentation. Androgen secreting ACC in women present with hirsutism and virilization, with male pattern baldness and oligomenorrhea of recent onset, whereas estrogen secreting tumors in males may lead to gynecomastia and testicular atrophy. Other rare possibilities are the aldosterone producing tumor presenting with severe hypertension and profound hypokalemia. And so other non-functioning ACC might present with abdominal discomfort or back pain. Tumor invasion into the IVC is not uncommon and may lead to complaints suggestive of DVT and lower extremity edema. Extension to the level of the right atrium may induce shortness of breath and be paralleled by the pulmonary tumor emboli. These things we have discussed that the functional tumors are obviously, as we have discussed, that in adults it is 50 to 60%. This percentage is much higher in case of children. Among them, those producing with the cortisol are 50 to 70%, and androgen axis in female patients in 20 to 30% patients. Estrogen axis in male patients is 5%. Mineralocorticoid axis is much less. Other non-specific symptoms, probably because of an abdominal discomfort by the large mass, that is 30 to 40%, and incidentally detected, as we have discussed, that is only 10%. Also, we should evaluate as like in case of any adrenal lesion, we evaluate for the glucocorticoid axis, other sexual steroid and steroid precursors to be looked at, mineralocorticoid axis, and also exclude pheochromocytoma. The imaging like CT or MRI of abdomen and pelvis and CT chest, FDG PET, bone scintigraphy or brain imaging when skeletal or the brain mets are suspected. Imaging adrenal mass greater than 6 centimeter, the likelihood of ACC increases dramatically. In one of the German cohorts, the median tumor size at diagnosis was 10.9 centimeter. So in size alone is a strong indicator of malignancy. However, stage 1 ACC with a diameter of less than 5 centimeter has the best prognosis, and it is therefore important to identify the adrenal malignancy as early as possible. Tumors between 3 and 8 cm represent a major diagnostic challenge. In children younger than 15 years of age, every adrenal mass is suspicious for malignancy. Although no formal imaging studies on this population have been performed, currently no single imaging method can equivocally determine that an adrenal mass is a ACC. So it should it is like know that only single imaging we do, and we are in a position to tell. So we might do CT, MRI, FDG, PET scan, also do clinical examination, biochemical workup, and then probably we are in a position to better tell whether that is a ACC more towards or not. We will also discuss in further slides. So heterogeneous masses and masses that remain indeterminate represent at least 20% of all adrenal tumors and are even more common among large tumors, necessitating additional diagnostic workup such as 18-FDG PET imaging. In patients with low risk for an ACC, follow-up imaging after 6 to 12 months can be performed. Multiplanar MRI is particularly suited to separating adrenal masses from surrounding structures like liver, spleen, pancreas, and kidney, and often gives a better evaluation for the vascular structures such as adrenal, renal, and the cavernous vein. Pre-op CT can be combined with chest imaging for the presence of metastatic disease. In addition to 10% of benign adenomas, pheochromocytomas also show uptake of FTG. Around 5 to 10% of primary ACC are even FDG PET negative. So this should also be kept in mind. Imaging with FDG PET has the advantage of simultaneously detecting mets at other sites, but metastatic lesions less than 1 centimeter, particularly in the lung, can escape the detection by FDG, indicating that FDG PET cannot substitute for the CT imaging. FNAC, there is a strong negative recommendation as it will not help to differentiate between the benign and malignant lesion, significant risk of bleeding with FNAC, Risk of tumor dissemination may also be, but it is low risk. Biopsy is 70% sensitive for ACC, so it sometimes be very insufficient for the application of the V's criteria. Indication for biopsy is adrenal mass without hormone axis and history of extraadrenal cancer to exclude or prove the metastasis. So what are the imaging characteristic differences between the benign versus malignant lesion? So as we have discussed, the suspicion of malignancy is more if it is a large lesion, shape is irregular, margins are irregular, texture is heterogeneous. If there is more calcification, necrosis, hemorrhage, if on non-contrastivity the Hounsfield unit is more than 10 Hounsfield unit, if contrast was out on CT protocol at 10 to 15 minutes, if absolute contrast was out is less than 60% and relative was out is less than 40%. MRI, there is no MRI chemical shift, FDG PET is avid. Staging high resolution CT of the chest in addition to abdomen and pelvis for early detection of lung mets. Specific imaging for brain and bones is only needed in cases of clinical suspicion. There is some evidence that FDG PET CT can improve staging at initial diagnosis or during the follow-up. Histopathology. It is gold standard for diagnosis, should be obtained in all patients. Most widely used is the WIS system. There are 9 parameters are assessed, scoring if more than 3 suggestive of ACC, sensitivity of 100% and specificity of 96.9%. If a score of 2 to 3 is borderline malignant, other systems can also be used. As we can see, these are the criteria. So nuclear grade, whether it is high, grade 3 or 4, mitotic rate greater than 5 per 50, high power field, presence of atypical mitosis, clear cells present in 25% or less of the tumor, and diffuse architecture greater than one-third of the tumor, and necrosis, venous invasion, sinusoidal invasion, and capsular invasion are also other important points. So total VZ score of 3 is suggestive of adrenocortical carcinoma. So these are the points we should keep in mind for histopathology. Other is Ki67 expression carries highly important prognostic information, must be part of the pathological report. In ACCA, Ki67 labeling index of greater than or equal to 20% is associated with poor clinical outcome. There are several markers also, such as melan A, inhibin alpha, SF1 has emerged as the single most useful marker to define the adrenocortical origin of the tumor. So SF1 is very important in that sense. It is a marker to define the adrenocortical origin of the tumor. ACC are typically negative for the chromogranin A and S100. So prognostic factors like Ki67, P53, beta-catenin, other germline susceptibility screening biomarkers to look for syndromic component MEN1, MEN4, P53, MMR, that is mismatch repair proteins for the link syndrome, beta-catenin, and APC, that is familial adenomatosis polyposis syndrome, succinate dehydrogenase subunits, uh, that is familial paraganglioma syndromes, also needs to be looked at.